is about what is new in the management of bariatric problem. And we have to admit that pharmacotherapy is now quite established thing, whether alone or with bariatric surgery or when with endoscopic surgery. So the debate now will be between one bariatric surgeon, exclusively bariatric surgeon, Mohammed Diaa Sarhan, and the other one is both a bariatric surgeon, originally a pediatric surgeon, an excellent one. But he is a bariatric surgeon and he is an endoscopic surgeon as well. So the debate will be whether pharmacotherapy with bariatric surgery or with endoscopic surgery.
Thank you, Dr. Fahim, and thank the whole board of Egyptian Society of Bariatric Surgery for this invitation. Thank you, Haris Khawaja, for great organization. It's my honor today to moderate this session about the future of weight loss surgery. As you know, from 19th century, from the start of bariatric surgery, past different stages, from simple jejunal bypass till the robotic surgery. So this session will discuss the next upcoming progress in this precise field. As I would like to introduce and invite Prof. Dr. Aida Qahtani and Prof. Dr. Mohammed Diaa Sarhan, two of the pioneers of bariatric surgery in the Middle East and even the world, to be in the stage to start this debate about comparison between anti-obesity medication and bariatric surgery versus anti-obesity medication and endobariatric surgery. Thanks.
Mohammed Diaa Sarhan will start. Professor Aid.
Good morning, everybody. It's really every year an honor and privilege to speak in the Egyptian Society of Laparoscopic Surgery Conference. Very proud of the biggest laparoscopic surgery conference in Egypt. Thanks to my mentor, Professor Dr. Fahim Bassiouni, Professor Dr. Hassan Shakir, and Professor Dr. Mohammed Haqi for inviting me today. And I congratulate Dr. Haris Khawaja for this very interactive session. So everybody is talking about
IT.
So every bariatric surgeon here is complaining about the decrease of the number of bariatric operations. The very famous conversation when I go to any bariatric surgery worldwide is surgeons talking about the decrease in their practice. And the conversation is, what is the percent of the decrease in your practice? Is it 30%? Is it 20%? Is it 50%? So it's a very important subject to understand for the surgeons. And when we ask ourselves about the golden era, like 7-8 years ago in the numbers of bariatric surgery, and now as we speak, and the decrease every year in bariatric surgery numbers, we have to think, what is the reason? Is it the decrease of obesity worldwide? Actually not. We can see here in this slide that the obesity worldwide is actually increasing. In 2015, more than 2 billion people worldwide were having high BMI, and 600 million were obese. In 2030, we are expecting that we will have 1.1 billion people with obesity. So obesity is increasing. And also 1.6 million premature deaths from non-communicable diseases like heart diseases, like diabetes, are being caused by obesity. So obesity is increasing worldwide. So why is the obesity surgery decreasing worldwide? We have to ask ourselves. Maybe because of the medications. Yes, this is one of the reasons. But then we have to determine if the medication should be our enemies as surgeons, or we have to work with the medications because we have to be practical. This is one of the very important methods of weight loss nowadays. So both should work together because obesity is a chronic disease and it will remain for years even after the surgery. So the metabolic and bariatric surgery with the obesity management medications, with the change of lifestyle should all change. So we have to accept it. As surgeons, we have to be practical. We don't have to fight the obesity management medications, and we have to work, but we have to learn how to work with these medications in our daily practice. And first of all, how do these medications work? The most famous are the GLP-1 and the GIP receptor agonists, work on the neurohormonal pathways that derive the appetite and the metabolism. So they work on the metabolism, they increase the metabolism, they decrease the appetite through the hypothalamic actions. So this is how they work, and this is how they can help the surgery. So the effect of GLP-1 agonists is to increase the insulin secretion, inhibit the glucagon secretion, and delay the gastric emptying and reduce the appetite, which can be very effective before or during or after surgery. So for example, what are the results of these medications that we all hear about nowadays? For the tirzepatide, which is the Mounjaro, as we all know, the 15 milligram dose, the maximum dose, had 20.9 mean weight loss at 72 weeks. While the Wegovy, the new semaglutide medication of dose 2.4 milligram, which is the maximum dose, is 14.9 mean weight loss, which are very good numbers or percentages of weight loss after or before or peri-surgery that can help us. So the very important question, when to use these medications related to surgery? We can use it either preoperatively, perioperatively, or postoperatively. We can use these medications preoperatively in order to control the surgical risk and the diseases related to obesity before the surgery. We can also use it perioperatively, which means immediately or with some time after surgery, because it will lead to better results of these bariatric surgeries. Or postoperatively on the long term in order to manage weight recurrence. And we will discuss each one separately. So we have to have the same concept of the oncologists. How do the oncologists think, or what are the stages of the oncology treats his patient? Step one, the neoadjuvant therapy. For us in bariatric surgery, the neoadjuvant therapy is like having the medications to control the obesity risk diseases, the obesity-related diseases preoperatively. This is as the neoadjuvant therapy. The primary intervention, which is the surgery itself, like the surgery is done for cancer, the surgery is done, and this is the most important or the critical step in the management of cancer and also of obesity. But again, after surgery, there is what is called adjuvant therapy, how you enhance or prolong the effect of the surgery that you have done. And finally, you have to have a second plan for the secondary intervention. What will happen when there is recurrence? Like when there is recurrence in oncology, in cancers, or recurrence in bariatric surgery, you have to know how to manage these patients. So in order to act, what is the neoadjuvant therapy is useful for? Number one, it reduces the perioperative risk. Having patients with higher BMI above 50 increase the risk by 3 to 4 folds before surgery. Number two, to downstage the disease itself, like the liver volume, which simplifies the surgery. Number three, to optimize the comorbidities like diabetes, like hypertension, if you want to optimize your surgery in the best way before surgery, especially very high BMI patients. So in evidence, there is 11.1 greater total body weight loss before surgery. So you can have your patient lose 10% of the total weight loss before the surgery. This is how we use the medications preoperatively. So what about the advantages of using these preoperative medications? It will decrease, according to these results, 24% reduction in the 30-day mortality for 0 to 5 if the patient lost 0 to 5% of weight loss. If the patient lost more, 5 to 10 or to 9.9% of the total weight, the reduction in the 30-day mortality will be 31%, and if more than 10%, it will be 42% decrease in the 30-day mortality. So, is the medications very safe? Does it have any disadvantages or side effects? Of course, like anything, as we all know, in 23% of the patients, they are complaining of nausea, 6% diarrhea, 10% constipation, 6% vomiting. It's also, there are safety-related conditions like the fear of having pancreatitis, increasing the risk of pancreatitis or thyroid cell tumors, or bowel obstruction and gastroparesis, which is very famous due to decrease of the gastric and intestinal motility. So this is when we use it preoperatively. So the second stage, we said that we can use the obesity management medications perioperatively, which means postoperatively 3 to 6 months. So we need to know when to initiate. There are several protocols when to initiate the medications postoperatively, either as early as 3 months post-surgery, or any patient from the start that we are not expecting good weight loss, or with symptoms of less response to surgery. So if a patient is not doing very well after 3 to 6 months after surgery, the patient and his numbers are not good enough in terms of weight loss, we can start immediately adding these medications to surgery in order to enhance the result of our surgery and therefore the satisfaction of the patient. This study is done collecting the data of 408 patients from 6 studies, and the GLP-1 analogs were used, and it was found that it has promising good results in terms of weight loss and improvement of comorbidities after surgery, and it can be used for unsatisfactory results of bariatric surgery. So regarding the weight regain, which is the long term of using the medications, when to use the medications after 1 or 2 or 3 years. When there are cases of weight regain, we can try this before surgery or even with revisional surgery. Number one, the factors that increase the incidence of weight regain is some physiological adaptations like the altered gut hormone, the decreased GLP-1 response, which is very high after surgery, but after 1, 2, 3 years, it decreased. The effect of GLP-1 increase after surgery. So we can add an agonizing factor by adding external GLP-1 analogs. The anatomical factors like the pouch or sleeve dilatation or fistula formation like the VBG. And finally, the behavioral and physiological factors, which is the change in the behavior of the patient. And then what is the evidence of obesity management medications? The results is 10% weight loss, total weight loss after surgery. So if you have a patient with unsatisfactory weight loss results and you use this medication, you expect an extra 10% total weight loss after weight regain or insufficient weight loss. These are results of some of the studies. It is 6% total weight loss at 6 months. In cases of weight recurrence, it is like 13% total weight loss, which is a very good percent of total weight loss after recurrence. So we can help a lot of patients who are complaining of weight recurrence or weight plateau or inadequate weight loss. and also the results are variable after Roux-en-Y gastric bypass, sleeve gastrectomy, and adjustable gastric band. Of course, the best results are with the adjustable gastric band because it has less metabolic effect. So the multiple trials confirm the safety and the efficacy of GLP-1 analogs post-metabolic and bariatric surgery. So it is not, there is no risk of using these medications post-operatively. So which patients should we start to think they will benefit more from these medications after surgery? From the very start, the higher baseline BMI. The higher BMI patients, we expect that we can use this medication and they will benefit more or they will need more these medications. Number 2, the patient with suboptimal weight loss or recurrence. Number 3, according to the surgical procedure. So we use it, we need it more with sleeve gastrectomy than Roux-en-Y gastric bypass. Or for patients with higher levels of comorbidity like diabetes and sleep apnea. Finally, what is the optimal time to start these medications? Either at when the patient reaches a plateau level of weight loss or 6 to 12 months post-operative. This is the best timing of starting post-operative medications. If the patient is getting a plateau, we can start using it, or you can use it without waiting for this plateau at 6 to 12 months post-operatively. So what are the barriers to use this combined therapy for the patient and for the healthcare systems? For the patient, 60% of the patient believe that the surgery is a cure. So when you tell your patient after surgery, you have to use medications, he just asks you, so why did I do surgery if I will use medications? So you have to tell the patient from the start that this is a combination that will agonize the result. Number 2, more than 50% of the patient reported that their surgeon did not explain the chronicity of obesity, that they cannot reach the ideal weight easily, or they may need another factor in order to reach the maximum weight loss. So regarding the healthcare system, the cost and the access, because it's not being embarrassed by the insurance everywhere, so this is an extra cost for the patient or for the healthcare system. And the perception of having lifelong medication can be a concept of failure after surgery. So these are what is as we consider challenging of using these medications after surgery. So what are the next generation? We all know the latest one, which is the Wegovy. However, two slides. However, there are 2 medications in the pipeline, the retatrutide, which they call the Godzilla of the weight loss medications, which reaches 24% total weight loss, which is very high percent of weight loss, and cagrilintide, which is combination of amylin and GLP-1 agonist.
Mohammed, will you sum up, please, because we are, yes.
This is the last slide. So it is this combination. The obesity surgery is like the engine that will help us to change. The fuel for this engine will be the medications, and the maintenance is the lifestyle and the exercise after surgery. Changing the lifestyle is the maintenance for this machine. Thank you very much.
Now, because we are, because of the sake of the time, Professor Aider Kahtani will give his speech.